Good morning, everyone. Today, I will be presenting the short and long-term results of endovenous laser ablation using 1940 nanometer laser and radial emitting fiber. After experimental evaluation, this innovative laser wavelength was applied in a clinical setting to evaluate and establish the short and long-term safety, efficacy, and effects on patients' comfort. Because this was a non-randomized trial, the results were compared to the currently available literature for EVLA using 1417 nanometer laser and radial fiber as benchmark. Patients with recurrent varicose veins, recent or past history of DVT or thrombophlebitis, and vein diameter of more than 15 millimeter were excluded from the study. The pre- and intraoperative details were recorded on a homemade protocol. The vein diameters were measured at various predefined points during pre- and postoperative duplex ultrasounds. Regular follow-up visits with clinical and duplex examinations were planned for up to 10 years. Parameters were set for evaluation of the procedure, and these were non-occlusion distance, deep vein thrombus distance, non-occlusion, and recanalization. Additionally, the results were categorized as Category 1 for asymptomatic patients with appropriate occlusion of the treated vein, no recanalization or no neoreflux in the accessory veins. Category 3 or red were EVLA failures with non-occlusion or recanalization of previously occluded truncal vein. A literature review revealed 3 studies fitting the inclusion criteria. All the patients were examined at 1 week and 1 month. Follow-up rates at 12 months was 72.8%, and at 24 months, 85 limbs, and at 36 months, 40 limbs were examined. The occlusion rate at 24 months was 96.5%, and only 3 patients developed recanalizations. New reflux was observed in 5% of the patients, and a very short average stump length of 1.6 centimeter was achieved. Minimal to few postoperative complications were observed in the postoperative period, and the incidence of paresthesia reduced from 6.2% to 2.2%. An interesting finding was that the diameter reduction of the ablated vein was significant over the complete follow-up period. Various segments of vein could not be recognized postoperatively in duplex ultrasounds. The present study was comparable in terms of the study type and procedures to the available literature for 1470 nanometer and radial fiber. We performed phlebectomies in all the patients and placed the fiber flush at the junction to the deep vein. With the above-mentioned protocol, EVLA was achieved with a lower average, cumulative, and individual lead for great saphenous and small saphenous vein. The complications like bruising and pain intensity were lower. Other complications like thrombus propagation and paresthesia and recanalization were comparable. Because of concomitant phlebectomies, the rate of reflux in accessory veins and redo operations was significantly lower. To summarize, with 1940 nanometer laser and radial fiber, EVLA is safe and effective even with lower lead requirements of 40 to 60 joules per centimeter. Occlusion and complication rates are comparable to 1470 nanometer. Reduced postoperative pain adds to patients' comfort. Shorter stump length and concomitant phlebectomies account for the lower redo operations. Thank you for your attention.